Well, good evening to all of you. It's a real pleasure to have you with us tonight, joining this week's webinar from the Royal College of Surgeons of England. And our subject tonight is something that probably is concerning many of you, and that's probably why you've joined us this evening. And it's the medico-legal implications of COVID-19 and surgical practice. So I'm very pleased to have with us as our panel tonight Professor Dame Jane Acre, President of the Medical Protection Society, who is a physician and rheumatologist and Director of University College London Medical School. We also have Ian Eardley, who is formerly our Vice President at the Royal College of Surgeons, Chairman of Council at Medical Protection Society, and practicing consultant urologist at Leeds Teaching Hospital. My name is Vivian Lees, and I'm a current College Council member, plastic surgeon in the Manchester area. So I'm going to ask Ian if he will lead off and give us his presentation, and then Jane is going to talk to us about some general principles. Thank you, Ian.
Thank you, Vivian. And thank you for having me this evening. Could I have the next slide, please? As Vivian's already explained, in addition to being a full-time practicing urologist, I am also non-executive director of the Medical Protection Society, which is a relevant declaration of interest. Next slide, please. What I'm going to try and do in the next 10 or 15 minutes is discuss in general terms the reasons that surgeons can get into trouble with patient complaints or litigation. I'm then going to talk about some of the specific issues that are relevant to medical legal risk in the COVID pandemic, and then try and give you some tips about how you might stay out of trouble going forward. Next slide, please. If we look at all the MPS cases over the past over a 10-year period, and this was a global series because we have members in lots of different parts of the world. These were the 800 cases that we settled, that effectively we lost, and you can see that the size of the claim was anywhere between £120, but the biggest claim that we paid out was £5.5 million. The greatest number of claims are in trauma and orthopedics and general surgery, followed by plastics, and MPS includes ophthalmologists within the surgical community. You can see that the other specialties account for substantially smaller proportions in terms of the number of claims, not necessarily the cost. Next slide, please. Broadly speaking, the cases break down into two types: something where there was a technical problem, such as inadequate performance, such as injury to some other adjacent structure, such as a cosmetic problem, retained instruments, retained swabs, not completing a procedure or putting in the wrong implant. And that's something I understand that ophthalmologists do from time to time. But the bigger proportion actually relate to non-technical issues, either not recording something that went wrong, inadequate consent, and with the advent of Montgomery consent, the consent process is, I think, different to how it was a few years ago. Lack of appropriate follow-up and lack of appropriate follow-up of results. So doing a test and then not looking up the result and notifying the patient, and that can sometimes be down to the fault of the individual, but it can also be the fault of inadequate systems or not having systems in place to review results reliably. Next slide, please. But broadly speaking, patients seek legal redress if they've had a poor outcome, perhaps a delayed diagnosis, perhaps a poor technical outcome from their surgery, or perhaps some sort of medication error. And that precipitating factor often sits on a background of what you might call predisposing factors: poor communication, interaction with their treating physician or surgeon. A surgeon who isn't necessarily sensitive to what the patient wants to get out of the surgery, and all surgeons know that not all operations go as they would wish, and so having a realistic discussion in advance with the patient about what the outcome might be and manage the expectations so that they're not expecting a guaranteed perfect result necessarily. And one of the little aphorisms that we have in MPS is that if you've not documented something, it never happened. And poor documentation of the process can underlie a claim and make it very difficult to defend in perhaps 30 to 50% of claims that are made against doctors and surgeons. Next slide, please. So with that general introduction, what I'm going to do is run through the things that have happened in the past 12 months that might potentially increase the medical legal risk for all doctors, but particularly surgeons. So next slide, please. First one is delay. We all know that since the advent of the pandemic, some patients have had delayed treatment. And if you think it through, there are three drivers for that. Certainly, during the first wave, there was undoubtedly a presentation delay. 2-week wait referrals went down, attendances at A&E went down, all sorts of reasons why patients didn't want to go anywhere near a hospital or indeed near a doctor led to a presentation delay with the symptoms, and they were putting up the symptoms perhaps that they might otherwise have done something about. When they did get to hospital, because of the number of COVID patients in the hospital, because of the ways that our diagnostic services were affected in radiology and endoscopy, there was often a diagnostic delay in getting to the bottom of their problem. And even now, as a surgeon, if they get onto a waiting list for non-urgent problems, they're going on to very long waiting lists that may be several months, if not a year or more. So delay, I think, is a considerable risk to all practicing doctors and surgeons. Next slide, please. Communication. I think there's two bits to this. We've increased the use of telemedicine, and telemedicine is quite different. Me speaking to you tonight, I can't see any of you. I can't pick up any of those little non-verbal cues that I would normally be able to obtain if I'm face-to-face with an audience or face-to-face with a patient. And there is the potential with telemedicine not to have a full or complete assessment. Clearly, we're not examining the patient, and for conditions where examination is relevant, that might be important. Next slide, please. But even where we do see patients with PPE, sometimes the patient's in a mask, you're in a mask, you may again not be able to tell properly what the patient says or means, and they may not be able to tell you what they say or mean. And just as a little anecdote, I've had dental treatment in the past 3 months, and I went to a dentist and they were in full PPE and I had a mask. They were talking to me about the drilling they'd just done to my tooth, and I could barely make out what they were saying to me because of the noise of the room, because of the noise of the ventilator in the room. So PPE, I think, also affects communication. Next slide, please. I think patients inevitably will begin to be worried that they might contract COVID while they're in hospital. In my own trust, a significant proportion of the COVID cases or have been acquired while patients have been in hospital. And I think it probably is only a matter of time before patients think and blame hospitals and doctors for acquiring that infection. This photograph was taken quite early in the pandemic of the sort of PPE that was being used at that time. I think most of you will now be using far more substantial PPE, and I think whether we were using PPE, to what extent we were using it, may well be relevant to these issues. Next slide, please. There's no doubt that doctors have been severely, doctors and nurses, the whole of the team have been severely affected in terms of their mental health by the pandemic. For those of you who've had to work on critical care, intensive care units in acute situations, there is a considerable risk of burnout. There's a considerable risk of being under stress. And when you're burnt out and when you're under stress, you don't always make the right decision. And I think it's likely that some of the decision making that's happened by very stressed members of staff, whether it's doctors or nurses or any other member of the team, may not have been necessarily as high quality as it would be when you are less stressed. And I think this is an issue and continues to be an issue. Next slide, please. What you may not know, and what organisations like MPS know, is that at times of economic recession, the amount of medical legal litigation increases. Quite why that happens, it happened during the recession of 2008, and it's happened in previous recessions. It's thought to be related to the monetary motive, whether it's from lawyers or whether it's from patients, but it is something that has been seen. We've not yet seen it within this recession, but it is a potential driver. Next slide, please. Many of us, myself included, worked outside our normal scope of practice. Certainly during the first wave, I was put in charge on a rota of a COVID ward, not a critical care ward, but a COVID ward where patients were escalated to and from critical care. And I found myself doing stuff that I'd not done for a good few years. I think many of us have been anxious about doing that, and I think many of us have leaned for support upon our physicianly colleagues when we've reached situations that we've not been particularly comfortable with. I think that sort of team working is appropriate, and I think it is has been far better developed during the second wave than perhaps it was during the first wave, but it has been a cause of anxiety, I think, for many of us, and perhaps remains so for quite a few. Next slide, please. Again, during both the peaks of the first and the second waves, we were all slightly anxious that the amount of patients coming into hospitals might be greater than the capacity of the service to deal with them, with the most acute issue during the first wave being the availability of ventilators. I don't think it ever quite got that bad. Certainly it didn't in my organisation, but ways in which we might be put in a decision in the position to make decisions what effectively account to rationing was a concern for many of us, and perhaps remains a concern. Next slide, please. Training, I think there may be quite a lot of trainees who have joined this webinar, and they will be well aware that surgical training has been affected significantly during COVID-19. As I understand it, about 10% of CCTs in surgery were delayed last summer. I think there's an expectation that that percentage will increase during the coming round of ARCPs, largely through a lack of surgical experience. And one can imagine that a young surgeon who reaches their CCT and takes up a consultant job may be particularly anxious during the early phases of their consultant career. I think really emphasising the importance of support from colleagues and formal mentoring and support in the operating theatre, should that happen. Next slide. An issue that's become, I think, relevant in the past few weeks with the report of the CQC is that there has been some criticism of some of the DNA CPR decisions, particularly in nursing homes. But I think this is a potential concern for the DNA CPR decisions that were made, particularly during the first wave and perhaps during the second wave. And that may, particularly if families feel that they were not appropriately consulted or supported in the decision making, may be the cause of litigation going forward, although I suspect surgeons will not be primarily the people that would be targeted for such litigation. Next slide, please. So if there are all those drivers, then when would we be likely to see the claims? I should say that at MPS, we've not yet seen any increase in claims. When we go to council, we ask the people who look after the claims coming in, and they categorically tell us that the claims have not yet gone up. But in many ways, we wouldn't expect it to do so. This is the typical delay curve that we see for claims versus events for our cases. And you can see typically the peak incidence of claims is that it comes in 3 years after the event, and sometimes many, many years later. So in reality, we don't expect to see any claims for some time to come. And indeed, other aspects of the pandemic, many lawyers are not working normally, they're not working in their offices. Access to lawyers is also not easy. It may be that there may be additional administrative delays that lead to further delay in those claims coming in. I think we do expect an increased number of claims, but as yet, we've not yet seen it. And we're certainly not in a position to quantify the degree of increase of claims that may be forthcoming. Next slide, please. So what can you do to avoid litigation? And in reality, the advice that MPS would give you, and I think this is advice that you get from the GMC or from the MDU or any other organisation who has an interest in this area, is no different really than it would be in any other situation. First and foremost, you must try and provide the highest quality of care you can for your patients, and provide and ensure that the treatment of that patient is as safe as it can be. You must try to ensure at all times that you communicate and interact with your patient and their family and their carers as appropriate, as well as you possibly can. And if there's more difficulties with telemedicine, then you simply have to do your very best to overcome those difficulties in order to make the appropriate decisions. The laws and rules of consent have not changed because with the pandemic, and again, the consent process is really just the same. It's all about the patient understanding what their options are, what the risks of those different options are, and being able to reach a joint decision with the surgeon or with the doctor about what the appropriate treatment is. And that's not usually simply about a signature on the morning of surgery, far from it. It should be about a process that begins in the outpatient clinic and may take a number of discussions with the patient in order to reach a mutual decision. I think the handling of patient disappointment and adverse outcomes is really, really important. I think there was an aphorism from a urologist who was actually the president of the Medical Defense Union, who said that if a patient liked his doctor and got on with his doctor, they very rarely sued them. And I think that is partly about good communication with the patient, warning them that everything we do doesn't necessarily work every time, warning them about risks, and then being open and honest should any of those risks or problems actually arise in reality. Again, communication with colleagues, whether it's members of your own team, whether it's the theatre team, the outpatient team, general practitioners, really, really important to get that right to minimise the risk. And I can't emphasise enough the importance of documenting accurately and fully all the steps in your management, in your discussion with the patients, and particularly in your consent. So next slide, please. So to conclude, I think patients will always complain, and they and there is a risk that they'll litigate. Primarily, they will litigate because they've had what they perceive to be an adverse outcome. Perhaps an adverse outcome they didn't expect. Perhaps it was the outcome you expected. Perhaps they didn't expect it. But they will tend to litigate if they're unhappy with the outcome. But they will do it on the background of a number of factors, particularly poor communication, particularly poor documentation, particularly poor preparation for what occasionally can be adverse outcomes from what we do. I think there is a genuine worry that COVID-19 and all that surrounds the pandemic will result in an increased number of complaints and litigation, although this has not yet been seen, certainly not at MPS, and as far as I can tell has not yet been seen at NHS Resolution or the Medical Defence Union or MDDUS. And again, I can't emphasise enough that litigation is best avoided by providing as high quality care as you possibly can, making that care safe, which is patient-centred, with good communication and excellent documentation. Thank you very much.
Thank you, Ian. A lot of food for thought there. So I'm just going to build on that a little bit. My name is Jane Dacre. I have to declare an interest in not being a surgeon. I'm a physician, but I have been involved in policy in relation to medicine and the way that medicine is practiced. So I will focus on those areas. I also need to declare an interest that I'm involved in the Medical Protection Society. I'm their president, and my role as president is to look after the interests of the doctors that are covered, doctors and dentists that are covered by the Medical Protection Society. So in a way, I'm the conscience of the organisation, ensuring that the organisation continues to have doctors doctors and dentists at the centre of what it does. And that's part of the role that the medical defence organisations have in supporting their members. So my own professional work has shown me that doctors and dentists need to be valued, supported and motivated by the system in which they work in order to do a good job. And there have been some wider policy issues recently that have happened that the medical defence organisations have been involved in that have made people feel a little bit uncomfortable about being supported by the system in which they work. So I want to just give you a few examples of those. The first is the issue of gross negligence manslaughter. If you remember, there have been a couple of very high-profile cases, that of Hadiza Bawa-Garba and also Dr. David Selou, who both were convicted of gross negligence manslaughter. Now, these were doctors who did not get up in the morning to go and do something bad. They were people who were victims of a system that essentially wasn't working very well, and they ended up making mistakes for which they were held accountable in the criminal courts. And this is something that the medical defence organisations find very difficult. And whilst it's essential that if somebody is truly exceptionally bad and negligent, that they're held to account, there is a nuance and a difficulty about somebody who has intent to do something bad and who doesn't. And in the main, doctors do not get up in the morning to do something seriously bad. And therefore, we believe that the law into gross negligence manslaughter and criminal convictions for doctors needs to have some discussion. Now, this was actually pointed out by Norman Williams, a former president of the College of Surgeons, in his review following the Hadiza Bawa-Garba case. But to date, there has not been a review of this. So the next thing that I'd like to move to is perhaps a bit more relevant to COVID-19. So what if, through no fault of your own, you make a decision which turns out to not be correct when you're on a ward that isn't your own ward, you're looking after patients that you might not normally be looking after under very difficult circumstances and where there are resource constraints. There is no legal protection against a criminal case being brought against you for something like gross negligence manslaughter or indeed murder. And one of the things that the Medical Protection Society has been trying to engage the government with is to have some kind of emergency law that would protect those that find themselves through no fault of their own, having followed all the guidance, with a vexatious complaint or a complaint from a patient whose relative, for example, may have died, that actually gets out of control. And the GMC's response to this is to say that they'll take the circumstances in which the doctor was working when they deal with those complaints, but there isn't actually protection in law, and that's something that we've tried but not so far successfully to engage the government with. Their view is that as people are covered by indemnity, that's enough. Now, when the complaints come in following the COVID outbreak, we have a concern that it might not be enough. The next thing is the GMC during the case of Hadiza Bawa-Garba appealed against the conviction of its own Medical Practitioners Tribunal service, and we have called for that right of appeal to be taken away. This is also something that was discussed by the Norman Williams review and also the Hamilton reviews, and the right of appeal is supposed to have been taken away, but in the heat of battle and with time progressing, this hasn't actually happened, and this is something that we want to try and keep reminding the Department of Health about, so that they do limit the right of appeal from the GMC against decisions made by the Medical Practitioners Tribunal service. Another thing which we feel quite strongly about is the need to prove negligence in order to get compensation in large claims. Now, this is something called tort reform, which is that we would like the government to consider looking at no-fault compensation where something goes wrong with a patient, and that it isn't necessary to chase the doctor in order to prove negligence for somebody who's been damaged to be compensated. So these are a number of different broad areas that we feel put doctors at risk. And those are in addition to the things that Ian has been talking about in relation to particular individuals in surgery. And these are areas where we feel that the system, the legal system and the Department of Health system ought to be looking at making life fairer for those doctors who might find themselves under difficult circumstances. So I think I will stop there. And I hope that you have some questions to ask us. So back to you, Vivian.
So thank you both for very clear, cogent and thought-provoking presentations. I do have some questions of my own, but I'll just put them on the back burner because we already had some written questions come in prior to the seminar. So I think this one perhaps to you, Jane. If the care of a paediatric patient is delayed for COVID-related reasons, and the child then suffers harm as a result of delay because it's a time-sensitive treatment, could that child have a claim in future years? And the example cited was of a urological condition leading to kidney dysfunction.
Well, I'm sure that any relative of a child that comes to harm because of a delay will feel pretty angry about it and will want to complain. And I think we maybe refer back to what Ian was saying about the communication around the case, the explanation around the case, and any mitigation that's been done to try and reduce the anger, reduce the concern, and therefore reduce the claim. But these things haven't as yet been tried out in the courts. So there isn't case law about delayed treatments related to COVID, and unfortunately we'll have to watch this space. However, the medical defence organisations will support doctors and will support them very strongly if the decisions that they've made were in good faith, following guidance, and under difficult circumstances.
And if I could add my own addendum to that question, is there any corporate liability on behalf of the trusts for the particular set of decisions they've made which may undermine the best clinical practice, that just poor planning, basically?
I think where there are resource constraints, and those resource constraints can be tracked back to the trust, theoretically there may be a case, but I think it's too early to tell whether in case law that will be proven to be a corporate liability. I think we just don't know yet. No,
okay. So can I ask perhaps Ian, this is more of a surgery planning question. Could you talk to us about prioritisation and review of elective waiting lists? Because category 4s could be on the waiting list for many months or years. And what is expected in terms of waiting list review? Thinking about who should do that review and how often. And how do we know if patients are coming to harm? How should we escalate instances of harm to record with the organisation, particularly if patients are off radar for a while? That's a question from Mr. John McGrath.
Yeah.
It's a series of questions.
Yeah, I've reviewed my waiting list twice since the onset of the pandemic. The first one was done as an internal decision by my own department, and everybody's had to do it again as a consequence of the government's diktat, I think, that hit the trusts last October, November. We ended up doing it during, again, December. That's what I've done. It was all done by consultants. It was all done in trust funded time. It was done instead of an outpatient clinic. We went through our waiting list and if necessary spoke to patients. And we've, any surgeon on the call who's got a waiting list will probably know that they've had to put patients into categories P1 to 6 according to their urgency. They'll also probably know that the FSSA, the Federation of Surgical Specialty Associations, have a guidance document which you can access through the college website, which looks at most, if not all, procedures for the surgical specialties and categorizes them in broad terms as to which category they should go in. Now, one of the difficulties of guidelines, I shall just digress, is that sometimes one patient who needs a particular operation actually needs it rather more urgently than somebody who needs the same operation. And that is something that is only known really by the doctor who's looking after the patient. So they, I think, have to, while bearing in mind these national guidance documents, have to bring their own interpretation of the individual risk to a patient. So you've got to take account of the guidelines, but then you've got to also bring into relevance the clinical need of that particular individual and therefore make a judgment on that basis. Ideally, it should be done in conjunction with the patient so the patients know what's happening, and quite frankly, all my P3s know they're not going to get their operation. They're all actually rather relaxed about it. They know that the world is still quite difficult. Whether they'll feel the same way in 6 months' time when they've still not had their operation, I don't know. And I think in the midst of the questions you asked me was how often do we need to do it? At the moment, there is no guidance. But my expectation is it probably would be prudent to do it every 6 months or so for an elective waiting list. But I think there are other bits. It's very easy for surgeons to focus on inpatient waiting lists. We've all, if my practice is anything to go by, I've got extended waiting lists to be seen in the outpatient clinic, particularly for patients who need face-to-face consultations. Face-to-face consultations are having to wait longer, and I've recently had to triage a face-to-face waiting list for outpatients. And I've identified patients who probably do need to be seen rather faster than the system is currently allowing them to do so. My trust has allowed me to do that, as my department has allowed me to triage our outpatient waiting list in the same way as we did the inpatient waiting list. But at present, that's not part of guidance. So I think that's answered all your questions. I think it needs to be done by consultants. It needs to be done in conjunction with patients. It needs to be done according to guidelines, but with individual patient needs part of it. It needs to be done regularly. Nobody's set a guidance for that yet, but I would have thought 6 months seems to be a reasonable timeline. Perhaps it might need to be sooner. And you asked me about identification of harm. I think right at the end of the question, if you do identify problems, so for instance, when I can give you a specific example. While I was identifying this triage of an outpatient waiting list, I came across a patient, and I'm a urologist. This is a man who developed urinary retention last February. He had his catheter removed, he was unable to pass urine, he had the catheter put back in, and he was booked to come back to clinic because he needed a face-to-face consultation. He hadn't been seen by November. However, he'd been admitted to hospital 3 times with urosepsis relating to his catheter. He had come to harm, which I've documented, and I've written a letter and I've explained that to him. I've actually seen him in the clinic since I did that, and he knows the situation, and he knows that I'm going to prioritise his TURP because that's what he needs. So it's not simply about inpatient waiting lists, but it's also about outpatient waiting lists. And I think that perhaps at the moment is something we've not necessarily focused on quite so much.
Perhaps from a physicianly perspective, we have, because I'm a rheumatologist and work in an outpatient specialty. So what we have is something called the partial booking list, which is the outpatient booking waiting list for patients for whom there are no slots. And so all of our consultants now go through the partial booking list and will either put them into a telephone clinic or a face-to-face clinic or write them a letter So I think keeping communication with the patients about these decisions that are made in their absence is really important, so that they understand they haven't been lost. We're still trying to sort them out. And on the whole, they're very nice about it.
Thank you, thank you. A follow-up to slightly earlier in our discussion, but in terms of treating children for surgery, is it the experience, and I don't know if you will have this in your practice, but are you seeing parents refuse surgery because of COVID? I have had a practice in children's hands, and I certainly have seen that.
I don't treat children anymore. So it's not something I'm aware of. I do have patients when we've done the validation of the waiting list who don't want their own surgery done for the time being until the COVID pandemic is over, inverted commas, whatever over means. But that was the question that we were told to ask them, and they don't want their elective surgery done while it's an issue. But no, I've not had to deal with children.
No. So next question, due to COVID, many rotas have been made non-residential. In surgery, patients can develop complications anytime, as we know. If there is a delay in attending a patient with serious acute complication, is it the fault of the doctor, or is it the organisation failing to provide appropriate cover? So that this is about withdrawal of the residential status which would normally pertain, and putting these doctors off site to come in.
That's a new one to me. It's not one that I've come across. It's not something we've done in our institution. The resident rotas have remained resident and the non-resident rotas have remained the same. I think the organisation clearly does have a duty of care to the patient to provide prompt care should something go wrong, and that is, I guess, the responsibility of the organisation. I don't know, Jane, have you seen that at UCL?
No, I haven't. The only thing that's ringing alarm bells and making me worry, and I'm not up to date on the details of the case, is that in the David Selou case, I think that he was tried for gross negligence manslaughter, and I think that he wasn't on site, and there was a delay in the operation that happened, and so I think it is potentially a risk and is something that we need to look out for and be wary of.
Certainly, delay in general is a risk. If a doctor doesn't see a patient within an appropriate timescale, if they're acutely ill, yes, that is a medical legal risk. David Selou was in a private hospital, and I think he was not on site. But it was the delay in getting his surgery done that led to the questioning in the case. As you know, the case was ultimately won on appeal.
Yes, but after lots of heartache, really.
Oh yeah, absolutely, yeah.
You know, a terrible time for somebody. So I think there are situations where, as a medical defence organisation, we do need to point out to the courts and to the GMC and to the government that doctors who are doing things in good faith need to be treated fairly.
Thank you. So this question is going to your presentation, Ian. It says the data presented from the MPS presumably reflects private practice. Do we know how reflective that is for NHS work?
No, we don't directly. We don't have access to the NHS resolution data. We are actually trying to work with NHS resolution to work together on the data, and we have some access to people there. But no, I don't know about that.
Okay. So here is a hypothetical, but if a patient has received now both doses of their COVID vaccine and presents for an emergency surgery without any relevant symptoms of COVID, should they be taken to a green theatre or a yellow, or indeed blue, even after sending their COVID sample?
I have no idea, and I suspect if you went to Trinity Trust, you might find that they'd be doing it slightly differently. There will be local guidance for such circumstances in each trust, and I couldn't give you an overall guidance for every trust in the country. The problem with these sorts of issues about which theatre you go to when, with a negative swab or 1 dose of vaccine or 2 doses of vaccines, is repeatedly changing, as I'm sure you know. And I think you've just got to be up to speed with your own guidelines and your own trust.
And ask your Director of Infection Prevention and Control. In my medical school role, we're trying to keep a lot of medical students in placements across trusts, and the individual COVID-related infection prevention and control systems vary between the trusts because of geography and various different things. So I think the thing to do is follow the local guidance as organised by the local infection control system.
Okay. So Lord Falconer is on record as saying that the pandemic will be a festschrift for lawyers. I'm not quite sure about that word. Never come across it. Matt Hancock has rejected a call for emergency legislation to protect doctors from inappropriate legal action. You alluded to that earlier. How can such inappropriate legal action be prevented? What can we do?
Well, we tried. We wrote a letter to the Secretary of State for Health to see if it was appropriate to have emergency legislation to protect doctors from vexatious, really, legal action or criminal action related to cases where they hadn't done anything wrong. And the government at the time felt that there was no need for it, that there was even a question in the House of Commons about it. So I think we'll just have to see these things through the courts and protect the doctors as much as we can.
It is interesting that other parts of the world have introduced such laws. The state of New York introduced such a law that effectively meant that a doctor couldn't be sued during their big first wave in the summer. So there are precedents in different parts of the world. The argument against, and I guess it is an argument, is that nobody wants to give carte blanche to doctors potentially to make errors, not only because that feels wrong for patients, but perhaps it might change behaviour. And so those are the two opposing arguments about litigation. I think the sorts of things that Jane was talking about, where we're perhaps worrying about prioritisation of acutely ill patients with respect to a ventilator or whatever, is really very difficult for doctors. And that, I think, was really the primary focus of our letter to the Secretary of State. It was those acute situations where you might have to make acute life or death situations where there's restricted capacity to care for patients.
And if I put my physicianly hat on and talk about my own hospital, there were times when the oxygen pressures were running low, when we maybe didn't have enough CPAP machines to be able to give them to everybody who might have wanted them or needed them. But what we did was we're very careful as patients came in with making carefully documented treatment escalation plans, so that it was clear what we felt was in the best interest of that particular patient. And somehow, with all of that going on, we managed to never quite run out. There, but by the grace of God, you might say. But I think somehow clinicians ethically discussed these things. We had an on-call ethics committee and we made decisions, and we never quite got to the crisis point that we feared.
So we now have a shared experience here. It's not really a question, but it's how about telephone triage of patients who've been waiting for a long time? Our questioner says they've done 50% of clinic assessments on the telephone and prioritised the face-to-face appointments. And by doing that, they've been able to bring down the number of patients waiting to be seen and have also reduced DNAs, so sharing some good practice there. I'd like to ask a question, and I haven't told our audience that Ian Erdley is actually a former chair of the JCST, so this is with your training hat on, Ian, if I may. But where we're prioritising different types of cases with this priority system, there are a group of cases who are really going to be delayed perhaps by 3 or 4 years, according to some of the comments that our President Neil Moore-Tenson has made in response to interview. He does anticipate a long time coming back from all that's gone on. But it may be that the same set of decisions keep being made again and again and again. So rightly, cancer is prioritised and these things. But the same set of trainees are going to be disadvantaged again and again with particular experiences. And we are seeing this in my specialty within hand surgery, where it can wait. And the problem is it always waits. And then in 4 years, we're going to have a group of registrars come through who simply haven't had the right experience. Can you see a situation where this is a 3-legged stool and we add another leg in, as well as the resources we've got, the mix of cases we've got, but we do add in a training priority somewhere?
I think we probably will have to. You know, there are lots of examples again through MPS. I'm aware of dentistry training, which I wasn't before, but I don't know whether you know, but they've stopped all dental trainees in Scotland from graduating, everyone. They put them all back a year, and they therefore put every year back a year. So the net result of that is there's no dental entry to dental school in Scotland this year. And they've done that, and so there's a year gap of people coming out. So there's going to be a workforce issue, and that's really where I'm heading. If the situation that you describe was to carry on for that length of time, there would be a workforce issue. There may already be a workforce issue. I know some specialties already had that before the pandemic started. And sooner or later, the government is going to have to deal with that workforce issue, perhaps by ensuring that those people who are not getting to do their cases that can wait actually have an opportunity to do so in some form of environment, simply to maintain the appropriate levels of workforce. The other suggestion that I know is being discussed is that those trainees are given a CCT, despite not having the full experience that they might have had pre-pandemic, but that they get additional support and monitoring, inverted commas, post-CCT in the first years of their consultant post. I think that's still a debate, and it's really an issue of whether you try to maintain the standard, in which case you'll have exactly the workforce issues that you describe, or whether there's a wish to temporarily perhaps flex the standard of CCT. That'll be a political decision. I'm not going to be making that decision. And I suspect that most surgeons would probably wish to see the standard of the CCT maintained at its current level.
So is there any equivalent for the physicians, Jane?
Absolutely. Well, the physician's got a lot of experience of respiratory medicine. But I think, going back to what Ian has said, there was a big workforce issue for physicians even before COVID. We are woefully short of consultants in acute medicine, and particularly far away from London. If you advertise a post in acute medicine, only I think around 40% of those new posts were appointed to because of a lack of suitable candidates. So in this country, we are woefully short of doctors. So one of the things that I think all of the medical royal colleges have been lobbying for some time, and I think need to continue to lobby for, is that we need more doctors. We need to increase the levels of the workforce. And one of the difficulties of that is that workforce planning has been a bit of a disaster forever. It's very hard to know how many of this or that you might need. And I can see in the chat, there's a comment about neurosurgery. I gather there are too many neurosurgeons at the moment, but there are too few of other things. And one of the things I think we do need to lobby about is workforce, making sure that there are enough doctors and we're flexible enough to put them in the right place so that they can supervise others, do their job and maintain the service. And at the moment, we're not in a good place.
And another question on what benefits we're seeing from vaccination. So vaccine doesn't seem to be changing protocols. Ian, you've partly addressed that already. We're seeing more and more patients who are frustrated as to why they're still in the yellow bay, even after receiving both their vaccines. What is the panel's view on how to deal with these situations?
I think this, again, I think this is something that'll change with time. I think as we're moving very rapidly with the level of vaccination across the country. And I think as the prevalence of people who are fully vaccinated increases, the protocols within hospitals will change. I think it's inevitable. It's just a matter of time.
And another helpful comment here, Section 11 of the Coronavirus Act of 2020 does provide cover for additional clinical negligence liabilities, specifically associated with COVID-19. Not something I've come across, but you will know more.
I think that in the UK, and I can see the next question down, it gets onto a similar issue. NHS resolution will take care of stuff that happens within the NHS. That's everybody who works within the NHS, working on NHS patients, will receive their protection from NHS resolution. And ultimately, the decision on any litigation will depend upon the individual actions of that doctor, whether they provided good, safe care, whether they communicated properly, whether there was an appropriate delay. I think where it becomes more tricky is if the complainant goes to the regulator, because NHS resolution does not cover complaints against the regulator. So if, for instance, I was referred to the GMC because of something that had happened during COVID, whether it was right or wrong, whether there was any basis to it or not, NHS resolution would not support me or protect me under those regulatory issues. And that's why doctors need to be a member of a medical defence organisation, because that's, whether it's us, whether it's the MDU, whether it's MDDOS, or whether it's another organisation, they need that level of indemnity to provide that regulatory support should it happen.
Indeed, I think the GMC recommend that too.
Yeah.
So we're coming really to the end of our session. I wonder if I could just ask you, both of you, to make one or two final comments, things that you would like our audience to perhaps take away with them. Is there anything we can say to reassure people who are sitting there now worried with some of the things we've said?
I would really emphasise the last couple of slides of my presentation, which is the principles of good care for patients are really just the same now as they were pre-pandemic. We have a few more obstacles in the way. Communication is perhaps a bit more difficult. Perhaps it's a bit more difficult to get patients to timely treatment, but it is important to talk to the patient, to listen to what they say, to take their needs and wishes into account, to document what you do properly, and to try to provide the best possible care, safe care that you possibly can. And if you do that, you probably will be all right.
So Jane, do you have any thoughts you would like to share with our audience?
Well, just another generally positive statement, that people go into medicine because they have a desire to be altruistic and to support people. And I genuinely believe that doctors, even surgeons, have that desire. And I think that these concerns about medico-legal issues should not be allowed to take away from the fact that being a medical professional is the most fantastic career, with challenge, with intellectual stimulation, and is something that is still worth doing. So enjoy it. Don't worry about it too much.
Well, I'd like to thank both of you for a really superb evening. I've taken away quite a number of points from that, but I do appreciate for those of you listening out there, some of these are quite challenging issues. So if you do feel that you need to reach out, we do have a confidential support and advice telephone line with a counsellor. The number's up there for you, 02786962221, and we will try to support you through these months. And just to say, it's been a pleasure. Thank you very much indeed.
Thank you, Vivian.
Thank you.